Okay, so this is a motion segment. First, I'm going to visually inspect for scarring, pimples, edema, anything that might affect the nervous scope. And then on palpation, I would be inspecting for boggy feeling on either side. For the nervous scope, I'm going to make sure it's turned on, make sure it's zeroed out and level. I'm going to make sure that my prods are at a good width. I'm going to go inferior to superior, go perpendicular to the segments, make sure there's no dimpling, make sure everything's pretty parallel to each other. I'm just going to go up in a decent speed. I'm going to go over 3 passes. I'm looking for a beak. If I beak on, say, for the left side, I'm going to mark the trailing in. Make sure that I get it 3 times. Yep, so he had left, so I marked the trailing in on the left. Then I'm going to spread out the prods for the thoracic. I'm going to do the same thing, just go down, looking for a beak, keeping an even pressure all the way through, make sure there's no dimpling or one-sided pressure. Looking for a beak. I find a beak going to the right, so then I'm going to mark the leading in on that side. Then I'm going to visually inspect for edema. If there's any boggy feeling or warmth on that spot, then that'd be the side that I'd be interested in. As far as the atlas goes, as far as the occiput goes, I'm going to contact the mastoid and C1. I'm going to laterally flex. If I feel that side close in, then that's okay. If I don't feel that side close in, since I'm on the left side, that'd be an LS. So this is the side that I'm interested in. I'm going to do the same thing for the right, contact the mastoid, then the C1. It falls in, so it's good. If it didn't, it'd be an RS. I'm going to then palpate for AS or PS. I'm going to take the head into AS and a little bit of rotation to the left. If I feel that it can't go AS, then that means it's stuck PS, so then it would be a PS LS. If I do the same thing on the right, I go inferior, superior. If it's stuck on the right, then it'd be an AS RS. Now I'm going to go for rotation. I'm just feeling to see if there's movement underneath. Oh, hold on, before I do that, I'm going to go anterior, inferior. If it won't go posterior, then it's stuck AS. So then it'd be stuck AS. So then it'd be an AS LS or an AS RS, just depending on which laterality I'm interested in. Then I'm going to do rotation. If it glides underneath, then I'm okay. If it doesn't glide well, then the side that doesn't glide is posterior. So then it'd be the posterior side, the other side would be anterior. Now I'm going to do the atlas, same thing. So I'm going to be on C1, C2. I'm feeling for the TVPs to close into each other. If they don't close in, that's the side of laterality. So it'd be a left laterality. On this side, I'm going to have the patient nod 3 times or 4 times, depending on however comfortable the patient is. I'm gonna examine. He's got a little bit of a downward angle, so he's got an anterior inferior on that side. Then I'm gonna go rotate again, just feeling to see if the TVPs move underneath my fingers. They do. If they didn't, that'd be the side that I'd be interested in. It'd be a posterior side, anterior side on this side. So if this side wasn't normal, then it would be a posterior over here. For the cervical spine, I'm gonna take my 2 fingers, I'm gonna have the patient flex. His open up normally. If they didn't open up, I'd be interested in the segment above, then I'd go rotation. For cervical, I'm just feeling to see if the spinous moves underneath my finger. He's got a little bit of issue going to the right, so he'd have a PR on this side. If he had flexion issues, then I'm going to go lateral flexion. Just feeling to see if these open up, if there's any restriction. He's got a PRS, so if it's normal, there's nothing. But if it won't, if he doesn't laterally flex very well and that spinous isn't closing very well, then that'd be a PRS since it's on the same wedge side. That he had rotation issues too. For the sacrum, I'm going to contact the PSIS or the SI joint. I'm going to rotate him internal, external. He's got good movement here. I'm going to go internal, external. The side that doesn't have any movement is the side that I'm interested in. So say if the left side doesn't move or close, then that's the side I'd be interested in. So I'm gonna have the patient stand up. So because it is, let's just say he does have a left side issue, that's the side I'm gonna be looking for on this. So he's gonna bend forward. I'm going to contact the PSIS. They should move up equally, and his do. Okay, so his move equally. If one side was up and the other side was down, that would show me a left side that I'm interested in. So I would look then at glute height. I'm just gonna make sure that that's taut so I can actually see the glute. If one glute was down and one glute was up, this side would be the AS, this side would be the PS or the PI. And then I'm gonna have him do a glute check. So PSIS, sacral base, I want to see this side come up. This side should move down. If it doesn't move down, it's stuck AS. Okay, and then I'm going to contact the opposite. Okay, move. Okay, it drops down. That's normal. If it didn't drop down, then it'd be a PI on this side and AS on this side. Then I'm going to check glute width. Okay, this side's a little bit wider. So this side would be an IN, and this side would be an EX if it was closer. And this side, since it is longer, it would indicate an IN. Go ahead and have a seat.
I'm going to contact the PSIS.
So then I'm going to contact PSIS with movement of his knee. I'm just checking for motion here. So I'm going to go out. It moves pretty well. If I didn't feel any movement, he'd have an EX. So I'm going to reset the knee and then go in, check for movement. If I don't feel internal rotation, then it'd be stuck in the internal rotation, or it'd be stuck IN, and then that's pretty much it.
Okay. I'm going to contact the